Thank you, ma'am. Hello, everyone. My name is Kelly Tang, and I'm one of the general surgery residents at William Beaumont Army Medical Center. Very happy to be here. All right, so we don't have anything to disclose, and that the views are reflected of the authors and not necessarily those of the Department of Defense. So, laparoscopic cholecystectomy is one of the most common procedures performed in the United States. During our literature search, approximately 20 people in the US have gallstones, and an estimated 300,000 cholecystectomies are performed annually. And among those individuals with gallstones, 20% are symptomatic and 1 to 4% develop complications related to gallbladder disease, such as acute cholecystitis, gallstone pancreatitis, choledocholithiasis, and cholangitis. So acute cholecystitis is defined as inflammation of the gallbladder that occurs due to impaired gallbladder emptying. It is diagnosed via a combination of physical exam, laboratory, and image findings as defined by the Tokyo Guidelines 2018. And furthermore, acute cholecystitis, like I said, can progress to complicated or advanced acute cholecystitis, with the mortality of complicated acute cholecystitis approaching about 50%. And the term advanced acute cholecystitis is a term that encompasses necrotizing, gangrenous, hemorrhagic, suppurative, and emphysema or perforated cholecystitis. So the neutrophil-to-lymphocyte ratio, NLR, is an exciting new metric for predicting acute inflammatory process. It's been well described in literature as a predictive factor both for the presence and severity of acute appendicitis. The normal NLR in a healthy adult ranges between 0.78 to 3.5, and in a 2020 meta-analysis, it demonstrated that an NLR of 4.7 was predicted of acute appendicitis with a sensitivity and specificity of 88.89% and 90.9% respectively. So preliminary data from international centers have shown that an elevated NLR in patients with acute cholecystitis. So in Korea, it demonstrated that an NLR of greater than or equal to 3 was significantly associated with severe cholecystitis, while in Serbia, they had demonstrated that the sensitivity and specificity of using NLR is about 78 and 74% respectively. And then a study in New Zealand also demonstrated a superior discriminative power of NLR versus just using white blood cell counts. However, this has not been explored in the United States nor in the military-dependent or retiree populations. So our study objective is to determine if NLR is predictive of both the presence and severity of acute cholecystitis as determined retrospectively by intraoperative and pathological findings in patients who underwent cholecystectomy at William Beaumont Army Medical Center. Our question to propose for the study was, do preoperative NLR scores correlate with the final intraoperative pathological diagnosis of acute cholecystitis? Our hypothesis, given the studies that have been shown internationally, is that elevated preoperative NLR scores correlate with both the presence of acute cholecystitis and complicated acute cholecystitis. So for methods-wise, it's a retrospective study. We collected data over a 6-year period, 2015 to 2021, from William Beaumont Army Medical Center, and utilizing electronic medical records, we obtained a list of cholecystectomies that were performed between that time frame, with our independent variables being neutrophil to lymphocyte ratios, and our dependent variables are intraoperative and pathologic findings. Exclusion criteria included pregnant patients, and for inclusions, it's pretty much everybody who has had cholecystectomy performed at Beaumont between 2015 to 2021. After our data collection, it encompassed a total of about 1,198 patients. This data set was presented to our statistician who refined it further, resulting in about 516 patients after removing what they called erroneous outliers and those without preoperative lab obtain. And from there, they did a Shapiro-Wilk test to utilize statistical assumptions to create a normal distribution of a data that was originally not normally distributed, followed by a t-test and point by zero correlation conduction. So here again, it's just showing a graph of how the patients were broken down. The statisticians' extreme outliers were determined as extremely high values that probably present an error in reading rather than a real measurement. On top of that, it could have been a typo in our data collection sheet. It was an Excel sheet. And on review of all of the data collected of those 1,100 patients, about a good portion did not have any preoperative labs. And upon talking to some of our attendings, if the patient had imaging study and the clinical exam and presentation, then a lot of times some of them may not obtain a preoperative lab. And then after the refinement, we had 377 patients who were diagnosed with acute cholecystitis, while 139 did not. So the variables in the study were normalized using a logarithmic function to facilitate accurate statistical analysis with the statistical assumptions to conduct a t-test and point by zero correlation. And this is the graph that came out to the distribution of values. The point by zero correlation was specifically conducted to examine the relationship between the dichotomous variable of whether or not a patient had acute cholecystitis and other continuous variables. As for our results, the point by zero correlation coefficient was calculated to be 0.18, indicating a statistically significant, though relatively weak correlation. And the t-test yielded a statistics of 5.47 with the p-value of less than 0.01. While the correlation may be weak, but the results are statistically significant. And there was rigorous refinement of the data. So preliminary data from international centers have shown that an elevated NLR in patients with acute cholecystitis, this has not been widely invested in the US. So this is the first retrospective investigation of data spanning 6 years at a single military academic hospital. The statistical analysis with a p-value of less than 0.05 suggests that the differences and associations observed in this study are not due to chance alone. Highlighting a significant distinction that patients with and without cholecystitis and NLR ratio and the NLR number, where patients with higher NLR have greater chance of developing acute cholecystitis. And this is what our study shows, is that the presence of acute cholecystitis and NLR. So there are some limitations that we do acknowledge, such as the lab errors that was seen with the reduction of the sample size after statistical refinement. On top of that, prior to the statistical refinement, the data set was not normally distributed, especially since about half of our patient populations did not have any preoperative labs. And additionally, this is a single institution. But we hope that for future directions to use the application of NLR to expedite patient triage and reduce time to definitive surgical therapy. And our goal is to hopefully be able to narrow it to a specific NLR cutoff, given that Korea had greater than or equal to 3 and New Zealand had about greater than or equal to 4.2. So a higher power study to investigate the ability to predict the severity of diseases needed. But with that, I'll take any questions. Thank you.